Cảm ơn bác sĩ Nguyen. Xin chào quý vị, đến tôi bác sĩ Gish. Anh hấp bác sĩ, anh hấp viêm gan C, viêm gan B, ung thư gan, sơ gan, and gan nhiễm mỡ a day. This is a very important liver disease, and we're going to go quickly through much information. These slides are available for review and download. If you go to my website, there's much information here for you. We have a very important evolutionary development taking place. We need to change what you see here today. There are a number of new terms, and I'm only going to talk about one on this slide, is this term called metabolic associated fatty liver disease, formerly known as NASH, Mafld. And there is a new term that may replace even this term called steatotic hepatitis. That word's not on this slide, but there's a discussion about changing the name further. You have to think about fatty liver as part of a multi-system disorder that's affecting the vascular system, the liver, pancreas, kidneys, and importantly, many other organs, including causing reflux disease that may affect the lungs. We already talked about orthopedic problems, gout, bladder problems, physical deconditioning, and a variety of other issues. So take fatty liver very seriously in discussing this with your patients, and we'll talk about those components next. When I talk to my patients in clinics, I give them this diagram, and I tell them when a person's overweight or obese, especially if they have fatty liver, they need to be thinking about each of these components. This is a way to motivate your patients to change their behavior. We use something called motivational interviewing. Motivational interviewing allows you to talk to your patients, ask them questions, and ask your patients to come up with a solution to their problem. They come up with a solution to the problem by asking why they behave the way they do. Why do they smoke cigarettes? Why do they eat too much? Why do they drink too much alcohol? And by asking these questions, you may be able to change their perception of their disease and allow them to live much longer by changing behavior. There are psychiatric disorders that are associated with fatty liver. Many patients with fatty liver are on different medications for anxiety and depression and other psychoactive medications. So fatty liver overlaps with psychiatric disease, as well as heart disease, kidney disease, cancer, and fatty liver as what we see as the core. The problem here is this word called lipotoxicity. Fatty liver is an inflammatory condition that affects every part of the body. Of course, we have to be clear that there is an overlap between alcohol use, alcohol abuse, and alcohol-associated liver disease and fatty liver disease, metabolic associated fatty liver disease. You need to take an excellent alcohol history, and we now use a blood test called PEth, P-E-T-H, to look at alcohol use. The PEth test looks back 6 weeks and tells you and tells the patient how much alcohol they have been exposed to. We call PEth testing the hemoglobin A1C of alcohol use and abuse. There does not appear to be any safe level of alcohol use in people with fatty liver. I take the position, it's rather rigid and strict, that if people have fatty liver, they shouldn't be drinking because there is no safe level of alcohol exposure. So this requires you to be very clear with your patients on why they should discontinue alcohol use until their fatty liver is resolved. Ultimately, fatty liver is associated with excess calorie intake. Many of my patients say, I'm not eating too much, or I'm not eating that much. They don't understand the idea that when they have obesity, they're overweight, or have fatty liver, that they're eating calories in excess of their activity level, excess of how many calories they're burning each day. So you need to be very clear with your patients that they need to account for their food intake. We teach our patients to count calories, weigh themselves daily, and then educate them on a healthy diet. This takes a team, a multidisciplinary team, to approach this. Going back to some terminology, we have hundreds of millions of patients with fatty liver. 15–20% of those individuals will develop advancing fibrosis. That number could be 30–40% if there's an alcohol effect combined with fatty liver. Cirrhosis and liver cancer, from a liver organ perspective, is that final pathway. But liver disease as a cause of death is number 3, behind heart disease and behind cancer. So when you see fatty liver as a gastroenterologist, as a hepatologist, infectious disease, you need to be looking at the whole person and working with the primary care, working with cardiology, working with endocrine to bring about a change and a treatment. There are many pathways here. These are the inflammatory pathways along the right side, driven by cytokines, adipokines, especially oxidative stress. On the other side is insulin resistance. If you have fatty liver, at least 70% of these patients are going to have diabetes or pre-diabetes, and that needs to be managed. My first step with my patients is to have them decrease and stop fructose intake unless the fructose is in the form of just natural fruits. Get rid of all the diet drinks, the sodas, places that we add different types of corn sugar and corn syrups. Fructose is directly toxic to the liver, directly toxic to the mitochondria, and this is how fructose disturbs the liver lipid metabolism as well as in other organs of the body. We know that excess carbohydrate consumption contributes, but fructose is the bad part of that carbohydrate and results in ATP depletion in the mitochondria. So the mitochondria are not just sick, but they're making less energy. Hot topic today is the intestinal microbiome. This interacts with the liver, the fatty liver. It can change from an oxidative or a reductive environment, depending on the specific food intake. A vegetarian diet is anti-inflammatory. I ask all of my patients with fatty liver to switch from a meat-based diet to a fish and vegetable-based diet. That's another component of the treatment for these patients, as well as weight loss, increased activity, and changing their food intake, including eliminating fructose. We have a big crisis going on because very soon fatty liver, NASH, Mafld, will be the #1 cause of liver failure and the cause of liver transplant, at least in the US, maybe the #1 cause of liver cancer. Of course, around the world, hepatitis B is the #1 cause of liver cancer. But if you put fatty liver together with hepatitis B, you may have a 10 to 20 times increase in liver cancer risk. So in hepatitis B, fatty liver is a very bad component. This is talked about the US, where we're having fatty liver as the leading etiology among liver transplant wait list recipients, people who are waiting for a liver transplant. Now, there is some controversy because certain centers say that alcohol is #1, other analyses say fatty liver, and I think in many patients it's a combination of alcohol and fatty liver. New guidelines have come out. I'm not going to walk through all of the details here, but the big important message here is every patient with fatty liver needs to be staged once a year at least, but I stage every patient yearly using free tests like FIB4, inexpensive tests like elastography that's available not just through FibroScan but other devices. And by staging the patients, you can move them into more aggressive management, including discussing risk for liver cancer and starting liver cancer surveillance. Now, there are people who have a normal body weight, and I see this very much in Asia, who have fatty liver. It's called lean Mafld, or lean fatty liver. They're not really lean, they're just normal. But the problem is, in most of these patients, they have an increased abdominal girth. They have increased fat around their intestine. It's called visceral adiposity. So in those patients, you need to start talking about measuring their waist circumference and trying to get them to move or mobilize the fat that's on their abdomen. There is some controversy about whether this has the same or higher risk of heart disease or cancer, but you can tell the patients who have a normal body weight that they're not safe. They have the same risk, I believe, at least as the patients who are overweight or obese. This just shows you, even in patients with a normal body mass index, that these patients still have a variety of different problems, including this atherogenic dyslipidemia. I'm extremely liberal about putting my patients on statins. I think statins are liver protective. Statins have an anti-cancer effect on the liver, at least, as well as metformin. And in these patients, they have a high C-reactive protein. It's another very simple test that allows you to look for inflammatory changes, even in the patients with what we call lean fatty liver. So lean NASH should be taken as seriously as patients who are overweight or obese or super obese. Fatty liver is a serious disease in these subsets of patients. Patients who have fatty liver are not normal. I mentioned before psychiatric disease, and it's not clear if the psychiatric disease leads to the fatty liver, but I think in reverse, people who have fatty liver end up having big changes in their quality of life. Less energy, decreased social functioning, decreased physical functioning. There are different domains that describe these individuals having a lower quality of life. Just gives you a little bit more information from a study from United Kingdom. I think this is true throughout the world. This is an inflammatory disease that makes people not sleep well at night. They have pain in their muscles and joints and other parts, decreasing family function, decreasing work function. You can motivate your patients to lose weight by saying you're going to feel better, you're going to have a better quality of life as you eat less, as you exercise more, as you lose weight. Back to progression. Not every patient with fatty liver will get progressive liver disease. I mentioned ranges could be from 15 to 40%, and I think the range is because of this exposure to alcohol. But you need to stage your patients, the people with progressive liver disease. You focus heavily on their liver. If they have mild liver disease, no fibrosis, you need to focus on issues of cardiovascular and cancer risk. This just talks about different ethnic groups having different profiles between Mafld and NASH. Mafld in this setting, in this study, was a non-inflammatory, non-fibrotic condition. NASH is an inflammatory process. And you can see that men have a bigger problem than women in this. Not sure exactly why. Of course, diabetes really drives a higher risk of NASH, inflammatory and fibrotic disease. Then you combine, on the right side, diabetes with weight, with hypertension. That's the highest risk group for progressive liver disease. This just talks about overall outcome, but I want to focus on this slide on one of my favorite liver enzymes. That's the GGT. In the United States, other parts of the world, providers talk about LFTs, which is a very terrible terminology, because when you describe liver function tests, people are putting too many tests together. Liver enzymes are AST, ALT, GGT, alkaline phosphatase. Liver function is bilirubin, albumin, and clotting. It's very important to separate function from enzymes. And the GGT is a surrogate marker, not just for progressive liver disease, but GGT has been linked to a higher risk for heart disease. So you can follow the GGT. It's a very simple, cheap test. As they lose weight, the GGT comes down, their prognosis, in my opinion, improves. In the liver, fibrosis or scar tissue drives outcomes. This is why you want to be staging your patients every year. Could be a blood test, could be imaging, could be a free test or one that you have to pay money for, but you need to stage your patients, stage them accurately, and stage them annually to see if they are on a trajectory to getting cirrhosis. If not, they're stable, mild disease over years. You can ask them to be much more involved with cardiology or cancer surveillance for their management. This just talks about liver-related, but in this study, people with fatty liver didn't have just liver disease problems, but they had a higher risk of overall mortality. That overall mortality I mentioned from cardiovascular disease and cancer, but we have to remember there's other issues that take place, including kidney problems. This is the causes of death in patients, emphasizing again cardiovascular, non-liver cancers. So liver cancer becomes a risk in people with advanced liver disease. It's interesting here that even infections are there. I'll have a slide in a moment talking about how fatty liver impairs immunology. This just talks about the different cancers that you can see at higher risk in patients with fatty liver disease. Patients do all have a fear of getting cancer. You can use this as a tool to motivate your patients to lose weight. I believe as people normalize their body weight, resolve fatty liver, their risk for cancer also goes down. This is the paper I mentioned about how obesity, and I believe inflammatory disease, fatty liver inflammatory disease, has a direct effect on immunity, decreasing immune function. We still need more studies to decide if that increases the risk of certain infections, but clearly people with fatty liver have a higher risk for having more severe COVID. That's just one example. So fatty liver is bad for the immune system, another way to educate and motivate your patients to lose weight. Motivational interviewing should be part of your tools today, talking to your patients. This just lists off why there's this cancer signaling that takes place: inflammation, DNA damage and mutations, changes in estrogen production, higher circulating level of insulin growth factor and insulin. I believe insulin is pro-carcinogenic. I try to have all of my diabetes patients off insulin if they have a normal or high C-peptide. So if you have patients with fatty liver in your practice, every patient who pre-diabetic or diabetic should have a C-peptide in their chart. A C-peptide, normal or high, stop their insulin therapy, put them on state-of-the-art treatment, which includes metformin, GLP-1, SGLT2, or DPP agents. NASH is the fastest growing cause of HCC among liver disease patients. We're starting to see hepatitis C go down a lot. Hepatitis B is flat. Fatty liver is increasing. Major issue. This looked at the VA population finding liver cancer in patients without cirrhosis. So I think about starting surveillance in my fatty liver patients when they're fibrosis level 3, F3, and I use the triple panel. Is available in Vietnam, but it's expensive, using alpha-fetoprotein, AFPL3, and DCP, or what I think locally is called PIVCA. A lot of data on this slide, but I'm just going to ask you to go to the far right. I think this pointer is working. Yeah. These are genetic modifiers of fibrogenesis. You heard a very nice talk about genetics here just a few moments ago. I believe sometime soon there will be a commercial panel that's going to put out at least 5 or 6 of these polymorphisms to help us tell patients what they're going to look like in 5, 10, or 15 years. This is, of course, is from a liver perspective. But there are many genetic modifiers of oxidation, endotoxins, cytokine activity, fatty liver metabolism, and back to insulin sensitivity. Every patient with fatty liver needs a full workup. We mentioned alcohol, but you also need to take a medication history. We're working on a project here on herbal medications. I understand in Vietnam, most of your patients come in and they're taking herbal remedies as well as maybe Western medicine. Take an herbal history, and I think most of the patients should be off these herbal treatments because there's no proven benefit of herbal therapies. We mentioned imaging. There's many, many ways to look at the liver. In the US, one of my favorite tools, if I can find it, is called a corrected T1. This is an MRI calculation that looks at inflammation and fibrosis in combination without a biopsy. Now, there's a lot of controversy about determining fibrosis levels, and people are now using combination. And they have something called indeterminate, but we're changing this word very slightly to call intermediate. If somebody's not low and they're not high, they're probably in a middle range for their fibrosis. But each year, you're going to go through a combination of at least a blood test or 2 blood tests and imaging, and restage your patient using 2 or 3 tests in combination. ELF test, ELF, is a blood test that's now available in Europe and the US. This is a very interesting test because the FDA clearance for this test is to predict the future. It's a prognostic test. You draw a blood test. You can use the blood test to also tell patients what their future looks like. I haven't ordered this test yet. I think it's around $500, so I haven't felt I had a clear justification to spend that money. But I think this is something that you need to know about. Diet works. These are different studies. They're not big studies. They may be open label or a case series. But when people lose weight, ALT improves. When people lose weight, fatty liver improves. This is especially in the setting of bariatric surgery. Very expensive, but that's the ultimate way to show that weight loss works. So when people lose weight, hypertension gets better, insulin management or insulin sensitivity gets better, better bladder function, decreased polycystic ovary symptoms and signs. Of course, the lipids are going to improve. Airway disease improves. Bone disease, osteoarthritis, knee osteoarthritis also improves. This is obstructive sleep apnea here. It gets better, including reflux disease. And of course, fatty liver improves, and we decrease cardiovascular mortality. Losing weight is key. This takes a motivational interview approach to motivate patients. It's interesting that a low-carb, high-fat diet works very well. I believe carbohydrates drive appetite, make people feel hungry. This is difficult in Vietnam to talk about a low-carb diet since there's rice, bread, other food every day. But a low-carb diet decreases appetite and helps people lose weight. Exercise works. There should be 3 hours a week of real exercise, fat burning, weight training, yoga. All those things should be part of an exercise regimen. So at least 3 hours a week. And part of that should be a period where the patient's heart rate is over 100, 3 times a week for at least 20 minutes. This helps improve metabolism and enhances weight loss. We have a number of anti-obesity medications that are licensed for treating obesity. I have used these in my practice. This is part of treatment algorithms, including the AGA. I never use pioglitazone. You've heard of pioglitazone as an insulin sensitizing agent. I think there's many side effects of pioglitazone, including weight gain, not weight loss. There is data that supports or suggests there's an increased risk of bladder cancer, heart failure, fluid retention. I don't use pioglitazone in my practice, but I do use metformin in any patient with prediabetes or diabetes. I think it's very effective as a foundation. Pivens is a study that said that vitamin E also works. In this study, they talked about pioglitazone as well, but I don't think the risk-benefit is there. But I do have all of my fatty liver patients on vitamin E, 800 IUs per day. There is some fake news out about vitamin E causing bladder cancer, causing other problems, but this is not true. It is true if you buy synthetic vitamin E, but natural vitamin E, in my opinion, is liver protective. ACE inhibitors. This is brand new news that ACE inhibitors for hypertension also can be liver protective. There's a variety of mechanisms that are listed here on ACE inhibition helping fatty liver management. So if you're choosing a blood pressure medicine in a non-cirrhotic patient, ACE inhibitors, I think, should be part of that discussion. If somebody has cirrhosis and portal hypertension, I'm using carvedilol. Not that it has an effect on fatty liver, but I think it's the best agent to reduce portal hypertension. Obeticholic acid was submitted to the FDA. They did meet their endpoint, which is improvement in NASH, improvement in inflammatory changes. They did not meet a true fibrosis endpoint, but they met the endpoint that the FDA agreed to. The FDA said, we're not going to approve your medicine because there's an increased risk of liver toxicity. There's still a dialogue going on. More recent data also showed obeticholic acid is not just safe in fatty liver, but effective. So I hope the FDA approves this medication this next year. GLP-1 agents are approved for weight loss. They were designed for diabetes, but in their label, they're also a medication that indicates weight loss in the 12 kilogram range. There are side effects, such as nausea, but the nausea is probably a change in gastrointestinal motility, stomach motility. The GLP-1s are the next step. There's a new drug that just had some data released, efruxifermin. This is a combination agent, works on GLP-1 and GIP. This agent also has shown excellent endpoints, at least in a phase 2 trial. Back to statins, you need to get that LDL and total cholesterol low. What is low? Probably total cholesterol in the 140 to 150 range. You want the LDL well below 80, and of course you'd like to see the HDL increase as well. So we have an inflammatory disease. It's very important that affects heart, cancer, brain function, quality of life, kidneys, liver disease, which we're talking about today. And of course, you want to counsel your patients not to smoke cigarettes. Smoking cigarettes has an enhancement effect on liver cancer as well. We rarely biopsy these patients. I didn't bring up biopsy today because liver biopsy is useful for clinical trials and maybe in 1% of patients with fatty liver otherwise. You want at least a 10% weight loss, but I'm really targeting them to get to a normal body mass index. I really want to focus on a BMI of 22 in Asian patients. Lots going on in drug development. Many new medicines listed across the bottom here. Probably 100 medications. And multiple studies showing improvement in fibrosis and stable fatty liver across a variety of studies, but none of these drugs are approved at this time. Finally, as a wrap-up, we're going to be doing personalized medicine approach for our patients, as you heard from the genetic talk a little earlier today, or about 1 hour ago. I think this personalized genetic approach is going to be very important. I think altering the biome, the microbiome, is also going to be very important. I want to thank all of you for having me. Professor Nguyen, thank you very much for moderating. Hung down my sister in this whole process. Long, thank you. My brother, my father, thank you so much. Sin Kemon Yu. India.
Thank you, Professor Gish, for an excellent talk. I would like to summarize for some sentence for the audience before we can move in. Em cũng xin phép các quý thầy cô và các quý vị đại biểu thì cũng xin phép tóm tắt lại một số điểm cơ bản của bài báo cáo này. Thì giáo sư Gish cũng có chia sẻ là ở trên trang của bác là www.robertgish.com ạ, thì có toàn bộ các cái bài giảng này. Mọi người có thể xem video, có thể xem các cái bài giảng dưới dạng PowerPoint, tại vì là bác cũng có rất nhiều bài giảng liên quan đến viêm gan B, viêm gan C, đánh giá sơ hóa gan, ung thư gan. Thì hôm nay bác có mang đến cho chúng ta một cái chủ đề cũng rất là hay, đấy là bệnh lý gan thoái hóa mỡ mà liên quan đến chuyển hóa. Tức là lúc trước thì chúng ta quen với thuật ngữ là Mafld là gan thoái hóa mỡ không do rượu, hoặc là NASH là viêm gan nhiễm mỡ không do rượu. Nhưng mà bây giờ thì cái khái niệm đó đã được chuyển sang thành là gan thoái hóa mỡ liên quan đến bệnh lý chuyển hóa. Thì cái thông điệp ở đây là bởi vì cái nhóm đối tượng này thường có liên quan mật thiết đến tình trạng của các bệnh lý chuyển hóa, đặc biệt là thừa cân béo phì, đái tháo đường và rối loạn mỡ máu. Cho nên là khi mà mình tiếp cận cái nhóm bệnh nhân này thì nó sẽ có một vài điểm đáng lưu ý. Thứ nhất là phải đánh giá toàn diện về các yếu tố nguy cơ chuyển hóa. Thứ hai là đối với đánh giá cái mức độ nặng của gan thì mỗi năm một lần mình phải đánh giá về cái phân tầng của mức độ nặng của gan, thì mình có thể sử dụng xét nghiệm phối hợp với các cái phương pháp chẩn đoán hình ảnh giống như bác nói về, mình có thể dùng elastography hoặc là fibroscan. Thì khi mà mình đánh giá đúng cái tiến triển bệnh lý gan rồi ấy, thì mình mới tiếp tục là xem là cái hướng điều trị tiếp theo là gì. Về các cái nhóm thuốc điều trị thì hôm nay bác cũng giới thiệu rất nhiều những cái nhóm thuốc mới. Thì cũng rất nhiều những cái nhóm thuốc trong này thì hiện tại chưa có mặt tại Việt Nam, nhưng mà có một số những vấn đề mình có thể áp dụng được trong thực hành. Ví dụ như là vấn đề liên quan đến giảm cân thì phải giảm được khoảng 10% số lượng cân nặng thì mới có các nghiên cứu khẳng định là nó có thể cải thiện tình trạng mô bệnh học. Thứ hai nữa là liên quan đến chế độ ăn uống sinh hoạt và đặc biệt là kiểm soát mỡ máu. Mặc dù statin không chứng minh được là cải thiện cái tình trạng viêm gan nhiễm mỡ, nhưng mà lại chứng minh được là thông qua cái rối loạn mỡ máu thì nó cũng có cái tác dụng ở trong điều trị. Ngoài ra thì kiểm soát tiểu đường tốt thì cũng là một cái khâu quan trọng ở trong kiểm soát cái bệnh lý này. Và ở nước ngoài thì rõ ràng là cái mặt bệnh này đang nổi lên như là cái yếu tố nguy cơ rất lớn của ung thư gan. Vì vậy trong tương lai khi mà cái kiểm soát cái virus viêm gan tốt hơn rồi thì chắc chắn đây sẽ là một trong những cái vấn đề mà chúng ta phải đối mặt. Once again, thank you so much for your talk. And maybe in the Q&A question you will receive more discussion.
Okay.
Thank you.
Thank you. Fantastic.